I'm Mark Pacifico, consultant plastic surgeon. I'm a past president of the British Association of Aesthetic Plastic Surgeons. I lecture internationally and teach a lot of young plastic surgeons.
I'm Nora Nugent, consultant plastic surgeon, and Bob's president 24 to 26, and ESOP's president 24 to 26 as well. I also lecture internationally, and I'm involved with aesthetic surgery journals. We put this together to inform you about what we do, why we do it, and about common questions that patients have for us.
We hope you enjoy it and find it informative.
Mark, we're living in the era of social media, Photoshop, heavily filtered images, and an expectation that anything is possible. How do you counsel patients ahead of surgery so that they can have realistic expectations about what they can achieve and expect?
This is really key with everything we do. I think one of the things I ask patients to think about and reflect on is why they're doing the surgery. What impact do they hope it will have on them, their lives, and not only in a physical way, but also from a psychological and emotional way. The second key thing for anything we do is to ensure people really understand their starting point, their anatomy, their skin and tissue quality, and appreciate that we can only work with how they present and we can't get them a catalogue to pick a result from. And I think, as you say, with social media, one of the challenges is people's expectations are often artificially high, and perhaps plastic surgeons are responsible in a way for posting.
One aspect of that is posting very early after surgery images, particularly after facial surgery, where swelling's still present and the final result isn't evident, or photographs in unrealistic lighting or non-standard lighting compared to the previous photo. So I think it's really important to have standardized photos to show a patient during a consultation.
Absolutely. And I think it's
long-term results.
Long-term results. And it's key that people understand that the advice we're giving is about them, it's personal to them, and it's realistic and honest advice. And that will help set their expectations. And then hopefully it will ensure they maximize their chance of a satisfactory emotional, psychological, and physical outcome.
I agree. And also the understanding that there is variation. No matter how much we try to predict outcomes, there is still human variation in how people heal.
Exactly. Can you tell us what patients can expect when they come to see us for a consultation?
Well, first of all, I think a private setting with their actual surgeon, and that might sound obvious, but it isn't always the case. And then really I start by going through motivations, what the concerns are, why is someone here, and what do they want to get out of the surgery. Then I'll do the physical exam, and then I can properly prepare my options, go through what the options might be, what's involved, the recovery, the risks, the expected results. And after that, we can come to a plan, or the patient can go away and think about it for a little bit longer.
And one of the things that I think we both are very mindful of is the psychological aspect from the patient's perspective, and ensuring that, as appropriate, we might involve psychological support and certainly support from our nurses as well.
Yes, and that's very important. And actually, we work closely with a couple of psychotherapists and quite frequently refer patients, and not necessarily because they have a psychological disorder, but as part of the preparation and resilience for surgery and the aftermath of surgery. And our nurses are also very helpful. And one of the things they provide is an appointment before surgery to go over the practical side of recovery, things like sleeping, scar care, garments, showering, the practical side of life, which doesn't stop. So once a patient has decided to have surgery, what is the next step? What is the process to actually having the surgery?
So I think it's best thought of as a journey, and the journey will involve a preoperative process, the surgery itself, and then an extended post-operative process. So before surgery, after a second appointment with one of us, a patient will see our nurses. The operation will be scheduled, and there's a series of appointments, initially with the nurses and then with us afterwards. What we try and do is to ensure our patients have as much information as possible. The first 3 appointments after surgery will already be scheduled at the time they book their surgery, so they have a really good idea of what's to be expected. And then there'll be longer term appointments over the first 3, 6, and maybe 12 months after surgery to ensure their result and that they are doing well.
And what would a typical timeline be between the first consultation and the surgery taking place, or does that vary a lot?
It will vary depending on the length of the surgery and time of year and our diaries, of course. And sometimes it may be as soon as a couple of months, sometimes it may be 3 or 4 months before a surgery date can be given. Tell us about the aftercare and what patients can expect after surgery.
For most of our patients, they will wake up from a general anaesthetic surgery with a tape dressing, and we use a particular sort of tape that's fairly resilient. For facial surgery, it's a brown colour, so it blends in better and it allows patients to take a shower. For breast and body surgery and for bigger face and neck lifts, they'll also have a support garment to wear between 2 and 6 weeks, depending on the exact circumstances. The first week after big procedures is important to plan properly. Can't necessarily move around as freely as you always did. You can't do the things you normally do. So plenty of time for everything, slow and steady. We have a routine for showering and looking after wounds. And then after that, you tend to turn a corner and life starts to get back to normal, usually over the course of about 6 weeks.
Yeah, it's a 6 week point that is that kind of the magic point, isn't it, for strength of wounds and people being able to start to gently exercise for most operations.
I say 6 weeks for lifestyle restrictions, 6 months for shape and swelling, and a year to 18 months for scars,
Yeah,
as a
it's
broad
fine.
outline. One of the things our patients worry about after our surgery is the scar. And obviously, we try and place them as discreetly as possible. But what are our routine recommendations for scar care after surgery?
I think one of the key things to mention just before I talk about that is the fact that for most people, probably 80% of what determines their final scar will be their genetics and their individual circumstance. And we as surgeons can influence the last 20%. And as well as meticulous surgery and taking the tension off the wounds as we close them, we will talk to patients initially about the tape that we use to support their healing wounds. And then we'll go on to talk about massage of the scars, and also use of other products such as silicone products that can be helpful to help scars mature. If there are issues with problematic or abnormal scarring, we might elect to put our patients onto a course of steroid injections or injections of other medicines that can help scarring. And occasionally for problematic scars, and this is fortunately not a common situation, we might entertain the concept of a scar revision or other treatments if needed.
Yes, so I think it would be fair to say we have a standard routine, but there are extra measures we bring in if we see a problem developing.
Having surgery is a big event. It's a life event, really. What do you find most people worry about in the lead up to surgery?
For facial surgery, they worry about looking unrecognizable or having telltale signs of surgery, particularly for facial surgery. After those concerns, I would say the next most common thing will be fear of a general anesthetic.
Yeah.
And the next most common thing is wondering, can they manage the recovery and aftercare process, and probably following that, scar care or scars themselves.
I think it's really interesting. And as surgeons who see people under general anesthetic every day, we are quite relaxed about it. We realize how safe and how well controlled it is.
Because we're working with experienced anaesthetists.
That's true. That's absolutely true. But it's amazing that the general anesthetic for virtually every operation is the patient's biggest concern, whereas for us, it's okay.
Yes, so we vet people before anaesthetics, so only if it's safe would we proceed.
Absolutely.
Mark, a lot of people worry about people knowing they've had plastic surgery. Is it obvious when a patient has plastic surgery?
Well, I think the key answer there is that good surgery should be pretty well undetectable. And that's particularly a concern with faces. And I always think the two things we want to avoid, the principles are people should still look like themselves, and people shouldn't have any stigmas or sign of having had surgery, like being overly pulled or have an unusual, abnormal pleat or fold. And then when it comes to the body, I think your practice is going to be pretty similar, is that we aim for our results to be as natural as possible. And I think what we mean by that is something that nature could have produced.
Proportional, not distorted.
Exactly.
And whispering, not shouting, I think.
Yeah, I like that. Yeah, whispering, not shouting. So with respect to the breast surgery that we do, what are most people's goals? What do we find people ask us for?
The key thing is most of my patients want a natural breast. They want an improvement in shape, often an improvement but in size, but not always, and to look like they have a natural breast that looks good but proportionate to them. And that might mean making some breasts bigger, making some smaller, and lifting others, or a mixture of all. But above all, patients want a natural and proportional breast compared to the rest of their body.
One thing that seems to resonate with a lot of patients that I talk to about this is this concept that if they were topless on the beach and someone were to see their breasts, they would be perhaps complimentary about them, but couldn't tell that they'd had anything done.
Yes, in keeping with the rest of their identity and their body. Why might patients come to see you about reducing the size of their breasts, Mark?
So breast reduction surgery is incredibly popular and it's incredibly satisfying for patients. And I think that's because it addresses functional as well as aesthetic concerns. The impact of large and heavy breasts can be profoundly debilitating. It can cause shoulder ache, neck ache, backache. Heavy breasts can result in a groove in the shoulder from the bra straps, infections under the breast, as well as all the psychological and emotional issues we hear all the time about patients telling us, when I speak to people, especially men, they seem to talk to my breast, not to my face. So you've got that psychological, but also that very functional aspect of breast reduction surgery.
And it's one of the most rewarding surgeries we do.
I think what's incredible is the almost satisfying guarantee we have as surgeons of knowing how happy that patient's going to be and what a difference to their life it's going to make afterwards. So why might patients come and see us about increasing their breast size?
So many patients come to see us about increasing breast size because they feel their breasts haven't developed properly, or they may have been very happy with their breasts in their 20s, but after having a family, 2 to 3 children, some breastfeeding, they've lost a lot of volume and no longer feel like their breasts are how they should be. So it may be about restoring volume, or it may be about increasing volume to give a more feminine shape, or to give patients the breast they feel they should have had.
And also, I guess, another cohort is the menopause and how that can affect
Exactly.
breasts.
Because menopause can affect breasts in different ways. They can become bigger or they can become smaller. It varies considerably. So quite often it's about restoring volume, but in some cases it's about evening volume if breasts are uneven, or it's about it giving a more feminine shape or more fullness to the breast. Do patients come to see you about having breast implants removed?
I think both of us share the group of patients who do have, they've either come to the end of their breast implant journey, perhaps they are having issues with their breast implants, or if they have had their implants in for a while, they will be that much older and the relationship between their breast and the implant will be different. The breast will be 10 or 15 years older as well as the implant after that passage of time. So we have patients who request for their implants to be removed, and that might be something they have done as an isolated procedure, or perhaps it could be combined with something else, such as a breast lift, as a common example.
And I think we sometimes see women who have had a change in body weight with menopause or pregnancy. So what fitted in times past no longer fits, as well as the natural aging process.
And also an
And
increasing amount of
weight loss.
patients with the weight loss jabs.
Weight loss medications, yes.
We all appreciate breast implants are lifetime devices. So tell us a bit about longevity of implants, about implant checks and that sort of thing.
So before I place any implants, I make sure my patient realizes that they are long-term rather than lifelong devices. So at some point they will change them out in the future. And that can be for a variety of reasons. We still say on average 10 to 15 years lifespan, but in reality, if there's no problem at 10 to 15 years, they don't have to be changed. But you should have them checked. And why might you change? Maybe a problem with the implant, like it's not in the right place, or it's now too big or too small, or you can get hardening of the tissue around it, or maybe it's that the overlying breast has changed and maybe it sags more after a pregnancy or after menopause. And sometimes it's a mixture of both.
And the other aspect that I think is less of a problem with modern implants is a tear in the shell of the implant. So a
yes.
rupture of the implant.
Yeah.
I don't like the word rupture so much because
No.
it sounds very explosive. It's more a small tear normally.
And sometimes we can pick that up examining a patient, and sometimes we would order an ultrasound scan to confirm the diagnosis. And that's something we're doing more and more in-house as well, actually. Mark, we talk about lifespan of implants and reasons to remove them. What surgical options are there for patients who have concerns about their implants or need to have them removed?
There typically will be a range of options to our patients. And one option that is nearly always available is removing the implants. And whether or not we remove the capsule, the scar tissue around the implant at the same time, will very much depend on the situation. And if we're removing the implants, we can think about whether or not we're replacing with new implants. We might take fat from another part of the body to use instead of an implant to provide some volume. We might do a breast lift at the same time, or actually sometimes we can combine some of those procedures to get the optimal outcome for that particular patient.
If the patient was in their, say 70s, would you consider replacing an implant or would you advise them against it?
That's a great question. And I learned my lesson very well from a patient of mine about 10 years ago who was in her mid 70s in exactly that situation. I learned that my presumption that she would just want the implants out was totally wrong. And all her initial emotional and psychological concerns that led her to have the implants in the first place 44 years previously came flooding back when I brought that up in the consultation. And I learned that it's very individual and age is not prohibitive. And in her case, we replaced the implants and she was delighted.
Health over age when it comes to, and patient wishes.
Absolutely. Tell us about fat grafting as a concept, as a technique for breast surgery.
So it's been around for a while. It fell out of favour initially, but is very much in vogue right now. I view fat transfer as a very, very helpful adjunct to breast surgery. It can be used to help the quality of the skin, additional padding over an implant, additional fullness in the upper breast, and sometimes the entirety of the breast augmentation or reshaping. But it isn't exactly the same as implants. It generally is a more subtle effect and it may require 2 to 3 procedures to get the desired result.
One of the places I really like using it is if a woman presents with quite a wide space between her breasts, it can be really helpful to add soft tissue
It
to
can narrow the cleavage.
Yeah.
It can narrow the cleavage in a soft way, a softer way than an implant can.
And I guess the other key point is we take the fat using liposuction. So someone's A, got to have fat present in order to be able to use it, and B, we've got to be very mindful about not causing an issue where we take the fat from.
Exactly. And often it's the overlying skin that determines whether or not there's an issue. So some places are, while technically you can take it from anywhere, some places are better than others. Mark, what is a tuberous breast?
A tuberous breast is really a descriptive term for the way in which some women develop a particular shape of breast. And typically there are a few features. Some women may have one feature, some all of the features, and they comprise of a constricted or a high and tight breast fold or breast crease underneath, a very large and often puffy or bulging areola, and frequently we'll see different sized breasts and a fairly wide gap between the breasts. And I think when we come to think about our way of approaching tuberous breasts, because there's such a wide range of how patients may appear and present, we really have to be very flexible with all the different surgical approaches and tools that we have, whether it's using breast implants, breast lifts, fat grafting, or a combination of those to address that individual patient in a very bespoke way.
I agree. We effectively need to keep all our aesthetic breast techniques in play for tuberous breast, because for one or both breasts you could need any of those techniques.
Exactly. And I think one of the problems occasionally we see is when surgeons have gone down a very specific path that they try and use for every tuberous breast, which means some will work very well and some really won't have the outcomes they could have got with other techniques.
Mark, could you tell us about your approach to gynecomastia or excessive male breast tissue?
So in the principle I try and achieve is to get the best result with the least scarring as appropriate. And broadly speaking, there are two patient groups I see: those who have developed gynecomastia or male breast development in puberty or perhaps through association with steroid use or other reasons. And they have very firm, very hard breast tissue within their chest. And I normally approach that with a small scar under the areola, remove as much, if not all of that, through that scar, and occasionally a little bit of liposuction as well. And the other group tend to be the patients who have lost a lot of weight and have a lot of excess chest tissue and chest skin. And in those cases, we're beholden to that skin dictating the scars that we use. But one of the key principles I like to achieve is to try and keep those scars in as subtle and natural place as possible, often around the chest muscle, to make sure they're as discreet as I can get them.
And this is one of the instances where you and I as well find the hemostatic net, which is an external row or rows of stitches used to hold the skin against the underlying tissue and help hold it in place to achieve better results than we used to
Yeah, I think different modern stitch techniques and modern surgical techniques can help do things that we couldn't do in the past. So really redistribute tension and allow us to place skin exactly where we want it and not let the skin dictate where the final scars are, which used to be the
And
case.
reduce risk as well,
Absolutely.
hematoma.
We both do many facelifts, and some of our patients are men. How do male facelifts, or approaching the male face, how does that differ?
There are some key differences for male facelift patients. One is hair patterns, both the chances of a shorter haircut and the chances of a different hairline if a patient has some balding as well. So we have to take that into account for scar placement. We also have to take the beard area into account because when you lift the facial and neck skin, it moves the beard area back towards the ear. Male skin is also thicker and it behaves slightly differently to female skin, and male anatomy is very different too. We don't want to feminize a male face when we're doing a facelift, so the way we lift or the direction and extent of lift is different in a male face. It has to really be tailored to the underlying bony structure and keep the masculine features.
Absolutely. There's an interesting kind of approach or thought I have with male faces is on the plus side, the tissue is often quite thick and quite good to manipulate. On the minus side, as you said, the male tissues are thicker and can bleed more and have other surgical challenges. So we do have to approach them slightly differently. So many people are talking about a deep plane facelift, which we both do. What is a deep plane facelift?
A deep plane facelift has actually been around for quite a long time. It's a very specific way of lifting the underlying support layer of the face, a layer called the SMAS or SMAS. And what it means is about 3 centimeters or so in front of the ear, in a line from here to here, roughly. After lifting the skin first, we slide underneath that support layer, and the rest of the facelift is a composite or dual plane lift, bringing both the SMAS layer and the skin together. It gives a very natural result. It has good longevity, and actually for patients with thin skin or who maybe had a lot of work done on the deeper layers of their skin, like fillers or deeper treatments, it can allow you to slide underneath that and essentially not have to deal with the impact of previous treatments.
I mean, I think it's been a real game changer because no longer are we thinking about lower facelifts. We're really lifting them in a much more harmonious way.
And you can lift the mid face as well as the lower face,
So-
not just the lower face.
So we get that harmonious lift around the top as well as the bottom of the face. And this is why I think contemporary facelifts really look so incredibly natural.
Yeah. I won't say I exclusively do it, but it is my lift of choice.
Yeah.
Why do you often recommend a neck lift with a facelift, Mark? Why not just a facelift or just a neck lift?
Well, I think what we've come to recognize is that the neck is the most aging part of the face. And if we lift the face and neglect the neck, we really have a very average result. And for many, many people, by paying attention to the neck, we also enhance and improve any lift we do for the face, particularly in this zone under the jawbone.
It's an overlapping area here, isn't it? And also they're right beside each other. So just getting a matching result is important.
Absolutely. And I think what's important to recognize as well is there are various structures in the neck that need to be attended to and won't simply be improved by lifting from the side. So often we're doing a deep neck lift with a separate incision under here in order to address some of those deeper lying structures, the salivary glands, the deeper muscles, deeper fat, and that can really help shape the neck to allow the neck subsequently to be lifted from the side.
Particularly in heavier necks.
So we're hearing more and more about deep neck lifts and submandibular salivary glands, or the glands. Tell us a bit about that.
The reason we're hearing more about it is because we are more and more realizing the difference it can make to a neck lift, particularly for patients with heavier necks. What a deep neck lift refers to is adjusting, usually contouring or reducing the structures that are deep to the muscle of the neck. You have the skin layer, then you have the platysma muscle layer, and it's the structures underneath that that are the deep structures. Salivary gland, fat, and sometimes the muscle layers as well. This is the superficial there.
And I was doing that as well.
And it's the layer underneath that that makes it a deep neck lift if we adjust it.
And I also find, and I totally agree, the heavier the neck, the more important it is. But even sometimes in a thin neck, the glands can be huge and it can really change the shape
Actually,
of the
in
neck.
very thin necks, you can see the underlying structures more clearly. So it's actually it's the two extremes of necks that benefit most.
I agree.
So for many people, the concept of a mini facelift or a local anesthetic facelift is very appealing. Is this something you would offer?
Rarely, in a word. And the reason is that what we really have learned is a sort of paradox, but the more we put in to facial surgery, the more natural someone's going to look, the longer it will last, and the more harmonious the result. And what we've really noticed and seen is that the more mini lifts, whether it's a sort of one stitch type lift or a mini facelift under local anesthetic, don't really address the face in a way that is very natural and may just lift the jawline. And maybe there's a small proportion of patients that will benefit from that. But really, if we want a good outcome that's going to be satisfying for the patient over the years to follow, we need to do things more comprehensively.
I agree. There's a small group of patients that it works well for, but most patients need a more comprehensive facelift that doesn't just address one very small issue and none of the surrounding areas.
So one of the things we both do during our eyelid consultations is talk about the eyebrows, and that's often a surprise to most of our patients, I think. So can you explain why we talk about eyebrows when we're talking about eyelids?
Yes, and it is a surprise to many people, but it's because upper eyelids and eyebrows are very intricately linked. There are a series of fine muscles above and below the eyebrow that control the eyebrow position, the eyelid position, how wide awake your eye looks, how well you open and close it. So you often have aging of both components simultaneously, and if you only correct one, not only have you not corrected the other, so you don't get quite as good a result, you've also altered the balance between the upper eyelid and the eyebrow. And most frequently, it's the upper eyelid that's done without the eyebrow, and the eyebrow actually moves down and doesn't help the upper eyelid result.
Yeah, and that's exactly the term, the technical term is compensated brow ptosis, which is a bit of a mouthful. But what tends to happen is because everything droops as we get older, including our eyebrows, our brains are very clever and they make us lift our eyebrows, or many of us, and I know I'm one of them, lift our eyebrows to alleviate that heaviness. And therefore, as you say, once we relieve the extra weight of the eyelid, the brain doesn't need to do so much work and often the brow comes down.
Yeah. And actually, I find in consultations showing patients a video of that happening before and after, or with a patient opening and closing their eyes, can be very helpful because it's not obvious otherwise.
Yeah, because we don't see ourselves
Yes.
with our eyes closed.
Exactly. What does lower blepharoplasty involve and what is it?
So lower blepharoplasty, along with many plastic surgery terms, is a bit of a mouthful to start with, but that's a lower eyelid operation. It depends on the individual situation of the patient. It deals potentially with skin excess in the lower lid, fat bulges, or even fat hollowness sometimes, and the overall appearance of the lower lid. And depending on the type of presentation of a patient, it's frequently an operation done under a short general anesthetic. Incisions are most commonly done under the eyelash line, but can be done on the inside occasionally. And the key is to restore the contours of the lower lid, releasing different ligaments and redistributing the fat pads and the bulging fat that really create those big bags in some people.
And eyelid, under eye bags or lower eyelid bags are a big problem for many people. So it is a frequent concern that we see.
So, Nora, you have a sizable rhinoplasty practice. So, can you explain about the operation, what's involved?
So rhinoplasty is a common operation for me, and it's done for a number of reasons. Mainly, I do rhinoplasty for reshaping the nose and making external changes, but quite often there's a component of reshaping internally as well to help with breathing. So the two primary reasons for doing it are either reshaping the outside of the nose or reshaping internally to allow someone to breathe better. It's usually a general anesthetic day case procedure, and there are a number of reshaping ways inside, but it involves reshaping the nasal bones and the nasal cartilage rather than the skin itself.
And how long does it take to appreciate the result of that work that you've done?
We usually say a year because it can take that long for the last of the swelling to settle down. But in reality, in some noses, it takes even longer, particularly if they've had previous surgery. And also, in reality, just like the rest of our body, our nose changes over a lifetime as well.
So tell us about the recovery following rhinoplasty surgery.
Rhinoplasty surgery is a surprisingly pain-free procedure. Most patients are fairly comfortable quite quickly after surgery, but what they find frustrating is that their nose will feel blocked. So in the early stages, it feels dry and crusty and blocked, and all you want to do is blow your nose, and all I don't want them to do is blow their nose. I also use an external splint for a week and then tape their nose afterwards for another week to help with swelling. And over the first couple of weeks, the worst of the swelling goes. Most of the swelling's gone by 6 weeks, but the final bit can take about a year to go. But really early on, it's key to just stay as elevated as possible so you get less swelling. Think about lymphatic massage treatments and generally just go slow and steady and avoid damaging the nose.
So it's more of a marathon than a sprint.
It's definitely a marathon. Mark, we frequently see women who come to see us because of the aftermath of pregnancy on their body or breasts. Could you tell us about the effects of pregnancy or weight loss on the body?
I think the most common issue we see is a combination of a few things. Number one is any skin laxity, skin excess. Number two is often functional issues with the tummy muscles that have been separated, that diastasis or separation.
Affecting the core.
Exactly, affects core strength, to the extreme that some women will tell us that they find it hard to get out of bed, and it really gives them back pain as a result of that weakness of their core. And then, of course, there's the variation in fat distribution that might need to be attended to as well. And the most common operation we'll do is an abdominoplasty, a tummy tuck, but that actually describes quite a wide variety of approaches, the most common one with the scar from hip to hip. But there are also other variations of that operation depending on the amount of skin excess and the way the skin has developed in terms of post-weight loss or occasionally post-surgery deflation.
Can you exercise your way out of it? That's a common question we get, or a common thing that women are told.
I think it is great to see patients who have done everything they can before they come and see us. Though they've done Pilates or core muscle exercises, they're down to a healthy weight, and they've really reached the point that they know that if they want any further progress or improvement, it can only be achieved surgically.
It doesn't go astray, but it won't correct all of the pregnancy changes once they're beyond a certain point.
Absolutely. And I think that's kind of also emotionally and psychologically important, that they don't feel then they're cheating or they're trying to get the easy route.
Yeah.
So why do women have labiaplasty surgery, and what's involved in the surgery?
Most women have it because of enlargement or discomfort of the labia minora, which are the inner labia. Sometimes it's the outer labia, but mostly the inner labia or labia minora. The frequent reasons that I see, and I see a lot of women for labiaplasty, are discomfort in tight clothing, visibility in swimwear or leggings, getting caught in underwear. Sometimes they find that it catches during intercourse. It also comes with a degree of self-consciousness because of these issues, and the two play into each other and really affect psychological well-being as well.
So it's physical and psychological.
It's very much a mix of both.